Good morning, everybody. I'm Bob Hickey of Pediatric Emergency Medicine attending. I have the distinct honor of introducing Dr. Desiree Neville for Grand Rounds this morning. I was given a one-paragraph introduction, likely written by Desi, which shows her humility, but hardly describes her talents and contributions. So let me expand. I've been in Pittsburgh since 1990. The start of my fellowship, when I accepted a faculty position, Sylvia Choi was chief resident and Ray Patetti was a fellow. 20 years later, things had improved, and Desi became one of a member of one of my favorite fellowship classes. Dr. Neville matriculated from Penn State University as an undergrad with a degree in bioengineering. Since then, she then went to the University of Virginia for medical school, followed by residency at CHP, and then again fellowship here from 2013 to 2016. In 2020, she completed the Leadership Academy for Early Career Faculty, and in 2021, she was selected by our Pediatric Emergency Medicine faculty and fellows for the Excellence in Teaching Award. 2023 was a very busy year for Desi. She became a member of the Society for Pediatric Research, was selected by our PEM faculty and fellows for the Excellence in Clinical Care Award, and was appointed director for point of care ultrasound and was promoted to associate professor of pediatrics. Congratulations, Des. Much of Dr. Neville's academic work has focused on Lyme disease. Desi is a site PI for the multi-center Lyme network, and let me explain. Whenever a Lyme test is ordered in our emergency department, our research coordinators approach the patient for an additional blood specimen, which is then sent to the biorepository in Boston, in addition to a case report form. This network has accumulated 2,500 blood samples in the last 5 years, and it has resulted in many publications. Desi currently has 23 publications. Many relate to Lyme disease. Desi's publications have informed and transformed my clinical practice. One of my favorites is her publication on the use of intranasal dexmedetomidine, Precedex, for laceration repairs in young children who are resistant to the approach used in presbyopia adult ED, which is hold still. This will only hurt a little bit. This research project won Desi the 2016 Pediatric Academic Society Ludwig Seidel Award for Best Research Project by a Pediatric Emergency Medicine Fellow. On top of this, Desi authored a book chapter on pediatric orthopedic emergencies that was selected as one of 12 required reading articles for the American Board of Emergency Medicine. As I mentioned, Desi is a recipient of our division's Excellence in Clinical Care Award. Let me give you an example why she earned this award. A few years back, Desi told me about a patient where she diagnosed Lyme carditis on an ultrasound. A machine I struggle to turn on. And I thought, holy buckets, Desi just made a diagnosis beyond my skills. And this is why we train others, not to be as good as we are, but to be better than we are. Desi personifies that experience and motivates me as an academician. Desi is a superstar clinician and educator. I look forward to her talk. Desi's Grand Rounds is a once-in-a-lifetime Grand Rounds. Seriously, the next leap year falls on a Thursday is 2320. Join me in welcoming Desi Neville.
Oh, well, thanks, Bob, for that wonderful welcome. I feel like I could just be done now. That's the whole talk. We're done. Thank you guys so much for joining me today. And I can't tell if anybody's online, but thanks for anybody joining online. I have a little QR code up there and it'll be scattered throughout. We had some polls. You won't be able to see the results just because the IT people don't trust me to download anything on the computer, but I'll be able to tell you the results as we go through. All right. So Noelle wrote this beautiful title for today. So Lyme disease loves the Burgh, updates from the Frontline. And really what I'm going to do today is talk about Lyme disease, but through the lens of some research that we do through the emergency department, and then just touch quickly on our clinical effectiveness guidelines. We're going to start with the obligatory Lyme disease slide. So we have our friendly tick sharing its spirochetes that ultimately lead to Lyme disease. And I know that you all know exactly how to care for these patients from Dr. Nowak's update. So we're really just going to kick it off with an easy case and spend most of our time talking about some of the research we're working on. Okay, QR code, that kind of works. We have a 5-year-old female for case 1 who presents with an isolated rash along her hairline in June. Family's concerned for infection or ringworm. You clinically diagnose erythema migrans, and they insist this can't be Lyme disease because she hasn't had a tick bite, and they demand a blood test. Welcome to my emergency department. All right, so for all our cases today, we're going to start by thinking about what stage of Lyme disease the patient's presenting with. So here we know we're in the early stage with a single EM. She has a single, non-raised, non-pruritic erythematous lesion that expanded to greater than 5 centimeters, so you can confidently clinically diagnose erythema migrans. But Dad still says, back in my day, I was covered in ticks in Western PA and I never got Lyme. This can't be Lyme disease. I need some kind of test. So our first quiz is to test or not to test. And you won't be able to see the results, but I'll tell you what you say. All right, you guys have hung out with Dr. Nowak for too much time. So everyone says do not test so far. So good, single EM, we vote do not test. So we all think that, but let's start by trying to get on the same page with Dad. So first, we'll kindly agree with Dad that while 20 years ago, Western PA had just a glimmer of Lyme disease, today is a lot different. You could show them the CDC map that shows the past 20 years of Lyme incidence. And if you look in Western PA, it's what we felt in medicine, that Pittsburgh went from a low area of Lyme disease incidence to heavily endemic. We'll give them a minute to think about that and pause the case. Now, during the pause, we'll talk a little bit about research. So the geographic spread of Lyme disease has given us a whole new crop of children with Lyme disease and with an opportunity to continually improve our diagnosis and management of this common disease. And that's where PD LymeNet comes in. So we're a collaborative emergency department-based research network comprised of 8 hospitals in Lyme endemic areas, all led by Dr. Lise Negrovich out of Boston. Those who are geographically minded will notice that all of these hospitals are centered in areas of high Lyme incidence on the CDC map. Our network has allowed us to focus on a large population of children with Lyme endemic or with endemic exposure to Lyme. A primary driver of our collaboration is enrollment in a study titled Novel Diagnostics for Lyme Disease. And Dr. Hickey hinted at this, but this study allows us to collect biosamples from pediatric patients in diverse geographic regions in whom the clinical team suspects Lyme disease. We're able to link the patient samples, which are housed in Boston, to demographic, clinical, laboratory, and treatment data for each patient. So currently, we're approaching 5,000 patients enrolled in the study. When we look at those patients, about 20% of them have Lyme disease. We also enrolled symptomatic controls, so patients who there was a clinical suspicion for Lyme disease, but their testing was negative and they didn't have an erythema migrans rash. And then lastly, we enrolled 8 age match controls. So these are asymptomatic kids who came in with a fracture, and then we enrolled them to be asymptomatic controls. And then here again are the study-wide numbers, and then in purple, you see our CHP numbers. But remember, this is 8 hospitals strong. So here are the study enrollment numbers again by year, showing the percentage of where they're enrolled. And this is just to show how hugely successful we've been enrolling patients here at CHP. So I credit this foremost to the awesome research structure and research nurses and team that Dr. Hickey put together for us, as well as our patient volumes, and maybe some tiny portion to the mountains of emails that my colleagues receive reminding them about my studies. This slide's just a testament to the hard work and really collaborative leading numbers we've brought to the research group. Okay, so with these large enrollment numbers, we've been able to begin working towards the primary driver for the biobank, which is novel diagnostics. So that we've already had some of our samples used by researchers who are investigating metabolomics or urine biomarkers for earlier detection of Lyme disease. And then we've been able to look at the test characteristics of some of our current testing options. So with that, just a quick reminder where our current Lyme disease diagnostics stand. So here at CHP, we use the standard 2-tier test. So we all know we get our EIA here, but it can be an EIA or an IFA first. And then the positive or equivocal results reflects to a Western blot. Everyone remembers the wonderful day in March of 2018 when we went from a many-day return of our test to a 2-hour turnaround. And then 859 emails and begging later, we went to 24 hours a day being able to get that test back. Some centers are using a modified two-tier test. So that's where their first tier is the same, but the second tier, they're using a more specific EIA. All right, so now we know where our testing currently stands. This paper is one example where our samples were utilized to look at available diagnostics. So they looked at over 4,500 patients, over 400 of which had non-cutaneous Lyme disease, and they established the test characteristics for various cut points. And with a cut point of greater than or equal to 3, they were able to show a sensitivity of 91% and a specificity of 99%. And so that's with one of the first tier EIA tests. And then here we just demonstrated some of the testing pitfalls we know, such as the low sensitivity of PCR in various fluid types in acute Lyme. Aside from amassing patient samples for novel diagnostics, a great benefit of our large patient enrollment and cohort development has been the opportunity for sub-studies within this population, because we have patients with Lyme disease in all stages of Lyme. Okay, now you know what PD-LymeNet is and why I got to talk to you today. So we're going to go into case 2. So now we have a 6-year-old male presenting with a full body rash and a low-grade fever. He had a fever 2 to 3 weeks ago with headache and fatigue, but no symptoms since. They've not left the house in forever. It's June of 2020 and have never seen a tick on him. So this cannot be Lyme disease. So again, we classify him. He is in the multiple EM disseminated stage. And again, to test or not to test? Well, the pie graph is much easier to see than for me to describe math. So I'm going to say most of you say test, and I don't know, 20% say don't test. So 80% test right now. So most people thought we do not test early disease, but we're going to test disseminated disease. Let's look at some research to back that up and to increase our family's comfort with our decision. So this is a paper we published with 192 children with physician-diagnosed EM. 187 of those patients had their clinical serology performed. So in this population, the sensitivity of two-tier clinical testing, and remember, some of those are the standard and some of those are modified, was 38.1% for single EM and 76.8% for multiple EM. So looking at those numbers, it's certainly reasonable to test patients in the multiple EM stage, especially if there's diagnostic uncertainty, as long as we do so knowing the limitation that we're missing a large percentage of patients with Lyme, almost 25% with our current testing. And with these sensitivity numbers, we can hammer home to parents that it doesn't make sense to send that test for a single EM stage. Importantly, any test we decide to do needs to be done with a really clear explanation of what those results mean to the parents. So they're not confused that with their perfect bullseye EM with a negative test, they can stop their doxy. So the main takeaway here is just that cutaneous Lyme is a clinical diagnosis. So we can all agree that cutaneous Lyme is a clinical diagnosis, but we think about all the different ways we sometimes fall short. Unfortunately, none of us are perfect diagnosticians except for Dr. Hickey. So we can think of a patient where they had, ticks loved him bed behind the ear, and you have your EM rash that you just see a little hint of here, but then if you don't have a high index of suspicion, search through that little kiddo's hair to find the rest of the ring. You might miss that's Lyme disease and call it cellulitis over and over again. So we obviously have some places where we fall short, and it's important to think of other ways that we know we might fall short. This is a study that we published last year where we found that Black children, when compared with children of other races, were less likely to be diagnosed with an erythema migrans lesion and more likely to be diagnosed with a swollen joint. So we can't over extrapolate this because not everyone gets an EM rash. It's concerning that we could be missing early diagnosis in this population of patients. And we know that our dermatology teaching images are historically light skin centric, which is not helping us. We also have time of year. This is June, to support the diagnosis of Lyme disease in our Lyme endemic area. We know that over here on the left, early and disseminated Lyme happen most in our warm weather months, May to November. And while the late stage arthritis, which is over there on your right, happen all year long. And then finally, the missed tick bite, my favorite thing to talk about with parents. So we can reassure the families with this paper that they're not alone in missing the tick. There's 1,770 children accounted for in this study, 325 of whom had Lyme disease. And when you look at the kids who had Lyme disease, overall, less than 20% of families and patients recalled the tick. It gets a little bit higher in the early stage, up to 40%, but all the other stages and overall, less than 20% of people notice the tick. All right, you've done a good job. You've made this family feel a whole lot better about missing the tick, and they wonder what they could do to prevent this in the future. Mom from case 2 shows you a picture of the kids playing in the backyard several weeks ago. So who can call out some things this terrible mom is doing wrong to prevent Lyme disease? All that skin, thanks. Yeah, so this one actually has bare feet in addition to all that skin. The CDC tells you should wear light clothing, keep skin covered. What else? You know, you're supposed to clear brush next to your yard. And you're supposed to have a fence between you and all the critters that drop their ticks in your yard. And then finally, I can tell you these kids don't have on DEET, let alone permethrin treated clothing. So we know exactly why this mom gave her kids Lyme disease. All right, so for patient 1, they have early disease and we'll get 10 days of doxy, 14 days of amoxicillin. And then in our disseminated patient, we will test them. They'll get an EKG done, which we'll talk more about in a few cases, and they'll go home with 14 days antibiotics. Okay, continue on to case 3. So this is a 5-year-old female flown in for concern for stroke. She has left facial weakness. What else do you want to know? So you guys can type in here, or if anybody in the room wants to talk. What else do you want to know about this little person? Where was she flown in from? I'm not going to name the hospital. Eyebrows raised, her eyebrows, what do you guys think? Her eyebrows do not raise. Well, at least the affected. Her left eyebrow doesn't raise. Right looks great. Wait for doxy dose. I love that. Wait for doxy dose. Where does she live? I don't know, but she came here. So other neurosymptoms, no other neurosymptoms. Tick bite, no tick bite. Nobody has a tick bite. 0% of people have a tick bite. What area does she live in? Far from the woods, never went outside in her life. Okay, recent fevers, myalgias. Nope, no fevers. No history of Lyme. Okay, awesome. Thank you guys so much for those questions. So we take a look at her. On your exam, she can't move the left side of her face, including she cannot raise her eyebrow. She has no other focal findings on exam. So the rest of her strength is perfect. She's awake and chatting with you. She doesn't care about this. And so then a lot of the questions you guys asked kind of walked us through this, this little flow diagram that helps us think about facial nerve palsy. So you guys asked, could she raise her eyebrows? And really what we're getting at, is this a peripheral facial nerve palsy, or is there a central lesion, which is going to take her on a very different adventure in our emergency department? Is there a history of trauma? So did she injure her facial nerve while it goes through her temporal bone? Does she have otitis or mastoiditis or HSV? So the answer to all those things are no. So now we think about any Lyme risk factors. So in our center and publications from other Lyme endemic centers, we know about 30% of acute facial nerve palsy that we see has positive Lyme testing. And we also know that Lyme cases are more frequent when it's warm. Some things that raise the likelihood are tick bite, a history of an EM rash, a headache, and fever when patients make things easy on us. But we know that none of those things are perfect, so we need to keep a high index of suspicion for Lyme and facial nerve palsy. A neurology group from CHOP published this paper in 2022, trying to answer the question of how to differentiate Bell's palsy from Lyme-related facial palsy. They looked at 306 children retrospectively. 27% had Lyme-related facial nerve palsy, 68% had Bell's palsy, and there was a 5% other group. When you compared the groups, Lyme, 93% presented between June and November. So easy, that helps us out a lot. When you looked at Lyme patients compared with Bell's palsy, they were more likely to have a preceding systemic prodrome. So fever, malaise, headache, myalgias, and arthralgias. 55% of the patients had that prodrome with Lyme versus 6% in the Bell's palsy and other group. What I take away from this and what makes me a little bit sad is that's only 55%. 45% of those patients with Lyme-related facial nerve palsy had no preceding prodrome. So still we have to think hard about it. I can't tell you how many times a day someone comes out of a room and says, they haven't had fever. I'm not testing for Lyme. You're like, okay, fine. We are, and then you have to go through this whole thing. And then they found that neuroimaging and lumbar puncture did not add any diagnostic value in isolated facial nerve palsy. And then out of the kids that they had follow-up for, so 226 of those patients with a combination of all the facial nerve palsies, everyone resolved but one at follow-up. And then they found no association between recovery and early corticosteroid use. Obviously, this was retrospective, so it's limited in that we don't know how long it took the patients to get better, and we don't know if there were subtle abnormalities. Okay, so the question of steroids always comes up when we think about acute facial nerve palsy. And there's really a background of adult studies, which is where that question comes from. And so there's adult studies of Bell's palsy that show improved outcome with steroids, right? But there's also studies of Lyme facial nerve palsy in adults that fail to show an improvement with steroids. And then one study that showed worse long-term outcomes when you give steroids to patients with Lyme facial palsy. And then we think about children. So there's this group out of Australia and New Zealand who described the current treatment patterns there, where a large portion of children with new onset facial nerve palsy were getting steroids. And then they described their protocol for a multi-center study looking at this, steroids versus no steroids in facial nerve palsy. Our CDC map didn't reach down to Australia, but while everything else there can kill you, they don't have Lyme. And then a group out of Sweden also described their plans for this randomized placebo-controlled study of steroids in their Lyme endemic area. This is from that New Zealand paper. And so they plan to enroll 540 patients in their study, and the report only includes 187. But they conclude that the vast majority of children got better without treatment. And although it was underpowered, it didn't show any evidence that early prednisolone treatment improved recovery at 6 months. So our adorable little patient comes back Lyme positive. And then after an EKG, she goes home with 14 days of doxy, no steroids, and importantly, we'll remember to give her some eye lubrication to protect her little eye until the facial nerve palsy resolves. Okay. Next case. All right, this is a 15-year-old male who presents with syncope, like everyone downstairs. He's now back at baseline, but he's intermittently bradycardic, and this is your EKG. All right, he throw in some EKG findings. Can you guys see the EKG on your little thing? They're all in the same thing. You have to go to the next one, Bob. First degree block, prolonged PR, first degree block. This word cloud is beautiful. I'm sorry you're missing out on it. But prolonged PR interval, first degree, wonderful. Woo! Dr. Aurora would be so proud of you. Okay, so our patient tested positive for Lyme while we were chatting about the EKG because of our wonderful fast turnaround. So now we've reached Lyme carditis, which is the manifestation that gives us the most palpitations. All right. I know mom jokes are a thing. Okay, so, but really this is the manifestation of Lyme we really don't want to miss when we're thinking about Lyme. So what do we do with him? Another poll. This is easy. Admit discharge. This is all you have to tell me. Admit discharge. Yay, I was hoping we'd have a mix for something. We're evenly split right now. Ooh, like perfect. 10-10, 11-11. We are perfectly split. All right, yay. We are split. So half of you say we're gonna admit, half of you are gonna say we're gonna discharge. So you gotta go talk to your friendly attending down the ED. This is a quick study that we'll just breeze through. So it was a study that I looked at EKG findings as a Lyme disease screening test while waiting Lyme results. Obviously, this was conducted while we were still waiting 3 days for the first year to come back, with the goal of not missing patients with Lyme, or at least not missing patients with Lyme carditis while we were waiting for that test to come back. We found that children with potential Lyme disease, if we found EKG evidence of carditis and specifically AV block, obviously, they were more likely to have Lyme. So we could treat them while waiting for our test, where otherwise we might have waited for the test. Just going through, obviously, because this is Lyme, the AV block was our most frequent finding. Kids were more likely to be older if they had Lyme carditis, present during peak season, have early disseminated disease, and were more likely to be admitted than their non-carditis friends. Less than half of patients who had Lyme carditis had any cardiac symptoms. Very few had abnormal vital signs. And then reassuringly, all the patients who had a follow-up EKG and had Lyme carditis had resolution of those EKG findings whenever they followed up. All right, this is a bunch of stuff about Lyme carditis. We don't have to go through everything, but really it occurs in 1 to 4%, 1 to 10%, who knows, some little percent of children with Lyme. We don't know the perfect number, as Dr. Aurora says, because we haven't taken every one of our kids with early disseminated Lyme and done an echo, an EKG, and a troponin. And obviously some of the carditis is not showing up on our EKG. We're just using that as a marker, so we're missing some kids. You know, the little spirochetes actually went into the cardiac tissue, caused inflammation, and that's what leads to our AV conduction abnormalities. We can also see other arrhythmias, myopericarditis, ventricular dysfunction, and we know that the AV block rapidly can fluctuate. And then there's cases that describe everything from cardiac pacing to needing full mechanical support. Okay, so what do we know about diagnosis and management? Well, we're sure about the extremes. Your friendly little patient with a single EM who is perfect with no syncope or cardiac symptoms, they could run right on home with their doxy. Who needs to come into the hospital? And this is pulled from the IDSA guidelines. But anyone with a high grade AV block, so PR greater than 300 or other arrhythmia, and then any clinical manifestations of myopericarditis. So you have palpitations, you syncopize, you're short of breath, you have pericardial effusion, we're worried about your heart function, you come right into the hospital. And then there's a gray zone. And that gray zone is because of, you know, our degree of uncertainty with the in the middle kids. The reason we think hard about that PR greater than 300, this is just from a case report that I pulled from online, but it nicely demonstrates how the AV block can really fluctuate. So that one time point where we're catching our EKG, they could have a different looking AV block at different times. And then there's several case reports that show a PR longer than 300 is associated with an increased risk of a sudden higher grade heart block that might require pacing while our antibiotics are getting in there and working. So you can see he bounced between 3rd degree block, 2nd degree block, blanky block, and then finally on day 5 when his Lyme test came back positive and he started antibiotics, he went down to the nice happy 1st degree block. So similar to this case, in most young healthy patients, their conduction abnormalities and their carditis is going to resolve with appropriate antibiotics. Okay, here at CHP. So this is the approach that we've decided, and by we, I say mainly cardiology. We are going to obtain an EKG in anyone with early disseminated disease, right? So if you're in that middle block that we've talked about, you're going to get an EKG. And then we're going to use the same criteria that we just chatted about to suggest patients could be at increased risk for severe cardiac complications. So all the things that we talked about and are listed there. And then the other block. So if there's evidence of Lyme carditis, your PR is elevated, but less than 300, you have no high risk features, so you don't have hemodynamic instability, you didn't syncopize, then you could treat as appropriate for whatever Lyme stage they're in, repeat the EKG with their PCP in 3 to 5 days, and then cardiology follow-up just if the EKG evidence of carditis did not resolve. If you have studied our guidelines over and over again, you will know that this is a slight change. So cardiology, having seen all 10,527 of these patients this year, they know that everyone gets better with a low-grade AV block, right? And so it makes more sense for that repeat EKG to happen at the PCP and not to have to send every child with Lyme carditis to cardiology. That means that we in the emergency department with low-grade AV block, who we're going to send home, don't have to call our friendly cards fellow to go over it with us because we know low-grade AV block can just go home. All right, so back to our friend. So 15-year-old male presents with syncope, now at baseline. EKG shows I got a PR of 300 to like 320, depending on where you do your measurement. And his first year Lyme test is positive. So armed with that knowledge, what are we gonna do with him? Admit. Okay, so he has syncope and his PR is at or above 300. So he's coming into the hospital to hang on telemetry while he beautifully gets better. So just a reminder, either his PR of greater than 300 or his syncope would have landed him in our hospital. So for him, he'll complete his 14 days of his antibiotic of choice, doxy or ceftriaxone or max, before making his way home. All right, moving our way through Lyme. So this is case 5. This is an 11-year-old female presenting with a week of headache, arthralgias, and now neck stiffness. She has an inability to flex her neck when she was seen at triage, and it improves somewhat with improves somewhat with ibuprofen, but it returned. She looks a lot better after a migraine cocktail, a lot better. She's chatting with you. She feels better. Her head still hurts a little bit, but much better. She still has neck stiffness. She can flex her neck, but has limitation. It's not completely normal. And her Lyme testing is positive. So we're concerned this patient has Lyme meningitis, right? We all agree on that. We less agree on what in the world to do now. So that brings us to our current R1 funded study, comparing effectiveness and complications of IV ceftriaxone to oral doxycycline for Lyme meningitis in children. So just a quick walk through memory lane. When the planning grant for this study was written in 2018, the hospitals that would eventually enroll in the study were surveyed. And the response was that 75% were treating children with ceftriaxone. And that included sending kids home with a PICC line. By the time the R01 was submitted in 2020, it was already moving towards more oral treatment, and now few patients get just ceftriaxone. This paper that Dr. Lise Negrovich published in 2021 showed with FIS data the transition from IV to oral antibiotics for Lyme meningitis. So when the discussions were first happening about this being a randomized controlled trial, I was confused, and for good reason. So our ID group, and especially Dr. Nowak, had been appropriately applying European data that doxy could be used for Lyme meningitis to our patients for years at that point. And I didn't know that people sent people home with PICC lines for Lyme meningitis. So sure enough, in 2019, our ID group described 38 patients with Lyme meningitis between 2012 and 2017. 32 of those received oral doxy at discharge and all had recovery at follow-up. And then in 2020, the IDSA guidelines were updated to include oral doxycycline as an equally effective Lyme meningitis treatment. Though they did note that the data that supported this was in European patients, but as Dr. Nowak said all along, the antimicrobial sensitivities and the antibiotic pharmacokinetics shouldn't be any different. So with our study, we just aim to show the non-inferiority of doxycycline compared to ceftriaxone in our pediatric patients, and also take a look at the complications. We all know the complications of sending a kid home with a PICC line. So we're enrolling patients 1 to 21 years with definite or probable meningitis who had a positive Lyme disease serology obtained within 7 days of enrollment. They get a bunch of stuff over 6 months, so quality of life surveys. We see their treatment, clinical laboratory follow-up data, and that's all cataloged for 6 months. So far, we've enrolled 85 of our 250 patient sample size. Purple is us up there, yeah. And I just want to take 20 seconds to say thank you. Thank you to all my colleagues in PEM and neurology and PHM for making sure I haven't missed a patient. So my favorite so far was a patient. I was at home at night and I got a call from the PHM attending, the ED attending, and my research nurse within an hour. An hour. That wouldn't have happened if I was in the ED. Anyway, it was wonderful. So thank you guys, because we're killing it. All right. So this young lady will get doxy for 14 days to treat her Lyme meningitis, and soon we'll have findings from our study to further support that approach. And everyone's favorite, we have a 12-year-old male. He has right-sided knee swelling over at least the past week, but of course he just told his parents today, so it's an emergency. He did have a low-grade fever a few days ago, and he is ambulating, but with a limp. So of course we've come to our late stage or arthritis. So what workup do you need? This could be fun. So in your little thing, oh, there we go. In your little thing, you could pick as many or as few, depending on who you are, out of these choices. Cliff note, I don't have a right and wrong answer for you, so vote away. Oh, is it working? Okay. Was that an ID consult? I missed it. All right, everyone wants a Lyme test. Know your audience. Good. The next most frequent is CBC, and then sed rate, and then CRP, and then synovial, no, blood culture, and then synovial testing, and 5 votes for a synovial PCR. Nobody wants an MRI or a ProCal. Listen, we are the only center in this little magical collection that don't send ProCals. So like, why did none of your patients have ProCals? I was like, what am I gonna do with it? I don't know. Okay, so we want a smattering of things, mostly a Lyme test, but a whole bunch of other stuff potentially. All right, so we've published some studies trying to answer the question of how much information do we need to rule out a bacterial musculoskeletal infection in a Lyme endemic area. This is a study of 1,423 patients with monoarthritis. 82 patients, or 6%, had bacterial musculoskeletal infection, and 28.5 had Lyme arthritis. The takeaway, looking at the common biomarkers we send, is that none of them have enough accuracy to be used in isolation. We know that. Not one test is going to make us all feel better, right? Dr. Negrovich published this paper back in 2013 that sought to distinguish Lyme from septic monoarthritis in a Lyme endemic area. And what they found was you can't say that someone's low risk for septic arthritis based on lab work if you have an ANC over 10,000 or a sed rate over 40. This is something you hear about if you're seeing these millions of children in our ED. We applied this rule to our population of patients. And so there's 580 children with knee monoarthritis included here. 543 had a research biosample and were included. 13 patients, or 2.4%, had septic arthritis, and 43%, or 234, had Lyme. We found that no patients defined as low risk with the prediction rule had septic arthritis. However, out of the 303 patients defined as low risk, almost 20% had a diagnostic arthrocentesis, over 5% had a surgical joint washout, 20% were hospitalized, and over 50% received antibiotics to cover for septic arthritis. So obviously a large burden of kids who are getting a little bit more treatment than they need. If you get to the arthrocentesis stage, there's another challenge to think about. And this is another paper published by Dr. Negrovich that shows there's considerable overlap of the synovial fluid finding in children with septic and Lyme arthritis. Like, shockingly sad overlap, right? So we really can't use that first synovial fluid to make us feel better one way or the other. And then we also utilized our patient cohort to evaluate the diagnostic performance of C6. So one of those first tier tests for Lyme arthritis, with the objective to determine if we could use the C6 EIA to identify children at low risk for septic arthritis. So this is a population of 911 patients with arthritis. You can see on my little skeletons, almost 60% of them were knee, 37% hip, and then a smattering of other. So out of 911 patients, 73% had a negative EIA, and then there's 27% with positive or equivocal results. None of those patients had septic arthritis, 84% with Lyme, 16% other, and then in that positive group, 30% underwent arthrocentesis. So really, what workup you need depends on your suspicion for septic arthritis, right? And that's what kind of where we're stuck. So if we have no clinical suspicion for septic arthritis, so you have a well-appearing patient, this is subacute, he says, I think it's been a week, it might've been 3 weeks, I don't know, I'm still playing basketball, but it's spread, you know, and they're well-appearing and they don't have fevers, then just Lyme testing is good. And we're gonna do good anticipatory guidance. If we're in the middle and we're unsure because he has joint rigidity and inability to bear weight, when we drill down the history, it's really only 24 hours of joint symptoms. We're not going to feel comfortable clinically rolling out bacterial musculoskeletal infection. And then we're stuck using our lab work for risk stratification. So including the ANC, the sed rate, and our Lyme tests. And then last for research studies, well, let me do a time check. Okay, we'll breeze through this quick. Last for studies, this is symptomatic management of Lyme arthritis. This has taken a complete back burner, sorry, Dr. Hickey and Dr. Nowak, to my other studies, that has a really interesting basic science background, and maybe someday I will finish it. So we all know that you get your tick bite, and then 3 months to 6 months later, on average, patients develop Lyme arthritis, and then they land in our care, right? Sad little Lyme arthritis. So we know the infection in Lyme arthritis gets better with appropriate antibiotics, but about 10% of patients develop post-infection inflammatory arthritis, even after they're appropriately treated and their infection is gone. And this leads to prolonged symptoms, prolonged treatment courses. We'll breeze through the science real quick, but for interest in time, in a normal inflammatory pathway, you get the prostaglandins and the leukotrienes, and they get your PMNs there, and they're causing inflammation, and they're helping eat your little spirochetes up, and then things get better. But for some reason, in patients with that persistent inflammatory arthritis, that level of inflammation stays elevated, and it doesn't return to normal. And it's been shown that mice with this post-Lyme arthritis, inflammatory arthritis, have elevated COX activity and elevated prostaglandin levels. So initially, Dr. Nowak wanted to conduct this study where we treat everyone with Lyme arthritis with NSAIDs, just so we can see if we can decrease how long they're inflamed, and if they get this post-infectious inflammation, which sounds like a good plan. Dr. Hickey, this is just saying that we know NSAIDs and other disease modifying anti-rheumatic drugs and biologic and things work for treatment of these patients, kind of like an inflammatory arthritis. And then Dr. Hickey found the question of whether everyone should get an NSAIDs interesting, because not only does the COX pathways make you get inflamed, but they also create lipoxins and that work with resolvins and protectins and these fun little chemicals that also get rid of your inflammation. So tell your PMNs to go away, or tell your macrophages to come eat your PMNs, and get your inflammation to resolve. And so the question is whether we could decrease inflammation, but potentially perpetuate it and make it last longer if we're doing too much NSAIDs. We all know the exact right amount. This is just more of that, sorry, we'll skip through for time. There are mice studies looking at this. And the interesting ones show that if you knock out COX-2 completely, so you have complete COX-2 inhibition, it's gone, that the mice had less inflammation, but their inflammation didn't go away. It just persisted forever. And then there's a more recent study this year where they took some of the lipoxins, the protective, can't think of the right word. Anyway, the lipoxins and the protective things, and put it back into the mice at the time of peak inflammation, and their inflammation resolved. So fun mice studies on it. But for us, I'm not a basic scientist. We wanted to see what we should be doing for our patients now while we figure out that data and develop this study. So we wanted to know if we give NSAIDs to every patient with Lyme arthritis, would they have a shorter arthritis duration? To figure this out, we enrolled patients who are diagnosed with Lyme arthritis. They're randomized to one of the medications that treat pain, is how we discuss it with the families, and then they get tech surveys. So the treatment arms are 28 days of naproxen, right? You're treating them with NSAIDs the whole time or until they're better. 28 days of Tylenol, which is our active placebo. It helps with pain, but it's not doing anything in this inflammatory cascade that we know of. And then 7 days of naproxen followed by 21 days of acetaminophen. The families then get this tech survey at a set number of days for 2 months afterwards. And then the tech survey lets them tell us about their joint symptoms, their medication compliance, medication side effects, and return to normal activity. And we just want to see if we can decrease the persistent arthritis and the duration of arthritis. Anyway, while we wait for an answer to that adjunct treatment trial, we'll send this patient home with 28 days of antibiotics, and they'll be better. All right, we made it through our whole spectrum of Lyme disease. This is just for me to remind you that we have 2 clinical effectiveness guidelines for Lyme disease, one Lyme disease, all inclusive, and one for facial nerve palsy that you can find on the InfoNet. Currently updating. This is just a reminder where we've been today. And then quickly, our funding. This is a bunch of funding that has helped support this work. And then all the acknowledgements. I think most importantly, Dr. Negrovich, who's an impressive scientist and researcher. She developed and leads PD LymeNet, and she's the mastermind behind all the science pretty much that I presented today. Dr. Spears, who guided me through my first study of Lyme disease facial nerve palsy as a pediatric resident when I didn't know what study meant, but it was really fun and I learned a lot, and who invited me to this Grand Rounds. Next, our ED research team. Without our research nurses, literally nothing would happen. Of course, our patients and parents who participate in all of these Lyme disease studies, and then all my colleagues in ID and Neuro and PHM who have helped with enrollments. Dr. Hickey, for research support, enthusiasm, knowledge, encouragement, and pressuring me to keep going. And all my other partners in the ED. This is Bob and Noel party pedaling. Dr. Nowak, well, for everything, not least of which having a world leader in Lyme disease right here at home to bounce everything off of. And then these are some of the other colleagues in different divisions who have helped me with the clinical effectiveness guideline development and helped out with some of our research studies. And last, my family for their contribution of pictures of all their Lyme disease manifestations. Thank you.